Hello, my name is Eric Secemsky. I'm the Director of Vascular Intervention at Beth Deaconess Medical Center in Boston, Massachusetts, and the Director of Vascular Research at the Smith Center for Outcomes Research in Cardiology. Thank you for inviting me to participate in this interview today. So we conducted the SAFE-PAD study to evaluate the long-term safety of peripheral Paraclitaxel-coated devices following a meta-analysis of randomized trials and published abstracts in the end of 2018 that demonstrated or suggested long-term harm associated with these devices. There are a lot of issues with this meta-analysis. In particular, only a few studies reporting mortality out to 4 to 5 years, which was the time point when the signal was strongest, and also substantial loss to follow-up, including more than 30% of patients in many of these trials. Typically, when there's a safety signal that we're concerned about, we conduct a randomized trial. However, this is a unique situation where we have a device that is guideline recommended for use as definitive treatment for femoral popliteal artery disease, and would require a trial to look at mortality involving more than 20 to 40,000 patients up to 5 years of follow-up, which would be almost infeasible and would be the largest trial ever conducted in the peripheral vascular space. As such, the FDA had reached out to find another mechanism of utilizing real-world data to evaluate the safety of these devices, to help understand if the signal seen in the initial meta-analysis was truly a causal relationship that could be reproduced. The SAFE-PAD study was then designed with input from the FDA to use Medicare beneficiary data or insurance data of patients age 65 and older in the United States to examine whether a signal of harm can be associated or found affiliated with these devices in this population. The SAFE-PAD report that was presented at the American College of Cardiology scientific sessions as a featured clinical research involved more than 160,000 patients, with more than 30,000 patients surpassing 4 years of follow-up, making it one of the largest studies presented to date and also involving one of the largest cohorts of patients with more than 4 years of data. So the study design was unique. We did a propensity score-based method called inverse probability of treatment weighting to compare patients who were treated with a drug-coated device, either a peripheral Paraclitaxel-coated stent or a balloon, compared with patients who were treated with a non-drug-coated device. These devices were only used in the femoral popliteal artery for peripheral vascular revascularization. This is a real-world study, and as such, we wanted this to be primarily unrestricted so that we had the patients represented and who we are treating in clinical practice. As such, we only required patients to have a year of enrollment in Medicare insurance to evaluate their comorbidity data in that prior year. Other than that, it was a rather unrestricted cohort of patients. Again, we used that inverse probability of treatment weighting to compare patients, adjusting for their baseline characteristics, and evaluated all-cause mortality for the longest period of follow-up evaluated for each patient. The study population was enrolled between April 2015, when the codes used for drug-coated balloons were approved in the United States, and completed at the end of 2018 at the time of the Kitsanis meta-analysis. We chose not to include patients after the end of 2018 because after that meta-analysis and the involvement of the FDA, we felt that a different patient population were being treated with drug-coated devices, really only those at the highest risk for restenosis and potentially those with guarded prognoses. And as such, we wanted to restrict the analysis to when patients were primarily within the standard of care period where we were using these devices more indiscriminately. We really thought a novel part of the SAFE-PAD analysis was the sensitivity analyses that we performed. The most common critique of observational real-world studies is the fact that it's not randomized. And so we know that there could potentially be biases in terms of how patients were treated with a drug-coated device versus a non-drug-coated device. However, we addressed this using multiple methods of statistical causal inference analyses to try to isolate and understand whether unmeasured confounding or treatment selection bias could be affecting our results. This took the form of instrumental variable analysis, a falsification endpoints analysis, and then also of examining whether how strong a missing confounder would need to be to overturn the results. The other unique part of this analysis is that we had a substantial number of participants, which allowed us to look at key subgroups that have come up as of interest in this study or in this arena. Some of these include isolating only patients who are treated in an outpatient setting, who tend to be lower risk, patients who were only treated with a drug-coated stent compared with a non-drug-coated stent, and similarly a drug-coated balloon versus a non-drug-coated balloon. And then also two populations, one with critical limb ischemia and one without critical limb ischemia. We use that inverse probability of treatment weighting to create two groups that were really balanced on their comorbidities. Now, interestingly, when you stratify these groups, all the patients, by whether they got a drug-coated device or not a drug-coated device, they're actually quite similar. They had very similar ages and comorbidity profiles before we had to do any methods of adjustment. And that was nice because we felt that that suggests there wasn't a lot of treatment selection bias concerns, whereas when we sometimes have seen studies done, there are two very different populations, such as those who get a mechanical support device during percutaneous coronary intervention or not. Those are two very different people. And when you try to adjust, you're still concerned about residual confounding. So we use this propensity score-based method, and we already had very balanced groups, but we refined those groups, made them particularly well-balanced. And that was our primary method of adjustment. And again, then we use Kaplan-Meier methods to evaluate mortality for the longest period of follow-up available. Of more than 160,000 patients analyzed in this study, we had a median follow-up of 2.7 years, and some patients follow up greater than 5 years. Again, the 4-year mark was when that mortality signal was the strongest, but at 2 years was when it was first visible. And of these more than 160,000 patients with some surpassing 5 years of follow-up, we saw very similar cumulative incidences of death throughout the follow-up period, with nearly overlapping cumulative incidence curves, suggesting no harm associated with these peripheral Paraclitaxel-coated devices. When we looked at these key subgroups, again, separated by those with the lowest burden of comorbidities, patients with critical limb ischemia or without critical limb ischemia, patients treated with a stent or a balloon, and patients treated either in an inpatient or outpatient setting, we saw very similar risk estimates, suggesting that the signal that we found for the larger group really was persevered throughout all the different subgroups, suggesting no harm signal associated with these devices across these key patient profiles. When we looked at those three important sensitivity analysis, again, the instrumental variable analysis, the falsification endpoint analysis, and the missing confounder analysis, we found that our primary results were very robust to any concerns about missing confounders or unmeasured biases. For instance, in the instrumental variable analysis, instead of examining whether a patient was treated with a drug-coated device or not, we looked at whether patients were treated in an institution that used a lot of drug-coated devices or did not use a lot of drug-coated devices. And the idea here is that if that patient went into one center, it didn't matter what characteristics they had, they'd be treated with a drug-coated device because those centers used a lot of these devices. They walked into a different center who don't use a lot of these devices, irrespective of their patient profile, they would not receive those devices. And when we leverage that variation in care, we found a very similar risk estimate and no evidence of harm associated with drug-coated devices. So an orthogonal view of our primary results, but again, demonstrating that the primary results were resistant to some measures of unmeasured confounding. When we looked at falsification endpoints, including acute myocardial infarction, heart failure, and pneumonia, these endpoints we would not expect to be influenced by drug-coated devices. But if there was an association, it might suggest that there was residual imbalance in characteristics that we didn't measure between patients treated with these devices. We found no association with drug-coated devices and any of these endpoints, which means that we were very comfortable with the idea that there was minimal residual imbalances or residual confounding between the two groups at baseline. And lastly, when we looked at the influence of a missing confounder, so how strong a missing confounder would have to be to overturn the results of this analysis, we found that not only would it have to be more prevalent, but more strongly associated with both drug-coated devices and mortality than any of the variables that we had already measured in the SAFE-PD analysis. As such, we felt it was infeasible that there was a particular missing confounder that we did not capture that would overturn these results. As such, we concluded that drug-coated devices were non-inferior to drug-coated devices were non-inferior to non-drug-coated devices in respect to mortality, with over 2.7 years of median follow-up and greater than 5 years of follow-up for some patients in this analysis. So I think there's two take-home messages. The first has to do with Paraclitaxel-coated devices. We've seen now that the signal of harm associated with these devices were only demonstrated in the pivotal trial data used to approve these devices in the US and some early randomized trial data across the world. And these studies were not designed to look at 4 to 5 year mortality. And that's why there was such substantial loss to follow-up and possibly other biases that were introduced to these analyses. These data have been looked at by Katsanos' meta-analysis, the FDA, and the Viva NAMSA meta-analysis. And as we saw, we found a harm signal, but that was attenuating or getting closer to the null when more follow-up was added to those patients. So those people with missing data were added back to the studies. However, every study outside of that randomized trial data, that pivotal trial data that had been analyzed, has not shown any harm associated with Paraclitaxel-coated devices. This includes the SWEDPAD randomized trial that was published at the end of 2020 in the New England Journal of Medicine, the sub-analysis results of the Voyager PAD study that were presented at TCT in October 2020, our SAFE-PD Medicare analysis that was just presented and published in JAMA Internal Medicine, and numerous other observational studies that have been performed across the country. None have been able to confirm this association between Paraclitaxel-coated devices and mortality. As such, I feel like now that we are several years away from this original signal of harm, we feel much more comfortable in that there is safety with these devices and that we probably should be getting back to using these at the level that we were before this controversy began. The other point that I want to make is that the SAFE-PD study was also meant to be a demonstration of how we can leverage real-world data to perform timely safety analyses for devices that have concerning safety signals. So we published our first Medicare analysis 6 weeks after the Katsanos meta-analysis, demonstrating some early suggestion that there was no harm associated with these devices. We are now just 2.5 years after that meta-analysis was published, and we now have a large study presented at the American College of Cardiology and in a big impact journal, again, demonstrating safety in real-world data that was designed with the FDA, had pre-specified analytic plan that was published in a methods paper in Circulation Cardiovascular Quality and Outcomes, and was designed to take into account many of the concerns we have with real-world data, in particular, treatment selection bias. So we hope that the SAFE-PD study really sets a template or an example of how we can use our real-world and observational data to evaluate safety concerns that may come about with cardiovascular devices in the future. So, the next steps now are really, we are going to continue the SAFE-PAD study because we agreed with the FDA that we would continue serial evaluations for patients until all patients in the study surpassed 5 years of median follow-up. However, we also, continue to work with societies and hopefully with the FDA to start to revisit the future of these devices and potentially loosening some of the restrictions that were placed on these devices. As I've described in this interview, we've accumulated a lot of information and data suggesting safety of these devices and not replicating that harm signal. So we're hoping that we get back to routine clinical practice in the near future and we can engage our regulatory officials to shepherd us through the process of reducing or releasing the restrictions placed on these devices.